So good evening, everybody, and thank you very much for braving the rain and the wind to come to Kiel today. Tonight's a special celebration, as this is one of the lectures in our inaugural lecture series, which gives us a chance to celebrate the success of our academic staff, particularly as they progress through careers at Kiel. My name's Christian Mallon, and I've got the huge privilege of being Executive Dean in the Faculty of Medicine and Health Sciences. And I'm delighted that tonight's inaugural lecture is being delivered by Professor Pensee Wu, who's Professor of Obstetrics and Gynecology and also an honorary consultant at the University Hospital of North Staffordshire. Tonight, Pensee is going to ask us the question, does what happened in pregnancy stay in pregnancy? It's a very relevant topic, lots of media attention at the moment, and I'm looking forward to hearing about Pensee's research. Professor Wu graduated from medicine from the University of Edinburgh in 2001 and undertook obstetric and gynecology training in Oxford and the east of England. She was awarded her Doctorate of Medicine and Research from Imperial College London in 2009. She completed maternal fetal medicine training in Glasgow, joining Kiel as a lecturer and honorary consultant in obstetrics and gynecology in 2013. She became senior lecturer in 2018, fellow with the Royal College of Obstetricians and Gynecologists in 2022, and professor of obstetrics last year. Her research, as I said, addresses a really important clinical topic: the impact of pregnancy-related complications such as hypertensive disorder, diabetes, and preterm labour on long-term maternal health outcomes. Her research has been funded by a wide number of different funders, including the National Institute for Health and Care Research and national charities. As you imagine, Pensee is very busy and also holds a number of other roles. I don't know how she manages to juggle them all sometimes with her research and her clinical work. But she's Research Engagement Lead for the Royal College of Obstetrics and Gynecology, Associate Editor of Frontiers in Cardiovascular Research, a member of the West Midlands Research Patient Benefit Panel, a member of the International Society for Hypertension in Women, and a member of the editorial board for BMC Medicine. So juggling a really busy portfolio that really highlights her research and the work that happens here at Kiel. On a personal note, Pensee is an amazing colleague. Every academic department wants somebody like Pensee there. She's caring, she's hardworking, she's compassionate, and she's a real team player. And as such, it's a real pleasure to welcome her to the stage tonight. Professor Wu.
Good evening, everyone, and thank you for your lovely introduction, Christian. I'd like to thank you all for being here on a winter's night. It's so cold and rainy, and so I very appreciate you guys being here. And for my inaugural lecture tonight, I'll explore the question that's shaped much of my research. Does what happens in pregnancy stay in pregnancy? And a little spoiler alert, not quite. But the journey there is what I'd like to explore with you. So a little bit about me. I was born in Taiwan. I'm the baby in the photo here. Oh, the mouse thing isn't showing. But anyway, I'm the baby in the photo sitting on my grandma's lap. In the same photo is my granddad, my parents, and my uncle. So my parents are basic scientists working at a med school. And I remember spending my weekends and summer holidays in the labs, seeing what mischief I can get up to with test tubes, petri dishes, and pipettes. And here I am in the top right-hand corner, aged around 10, along with my mum in the red top. And I'm sitting there listening to presentations from medical students talking about their summer research projects. So research has been in my life since I was very young. And when I was 12, I moved to the UK because my parents they both were funded by the government to do a PhDs at University of Edinburgh. So I moved along with them, and I moved from a mainly Taiwanese population to the UK, which is much more diverse. And of course, as you can imagine, it was such a culture shock. But I enjoyed making new friends, both at the school and in the orchestra. Following my parents' footsteps, I graduated from University of Edinburgh, and then I started doing my residence training across the country. So I started in Edinburgh for my first job in obs and gynae. I've always wanted to do obs and gynae because I always wanted to help pregnant women. Later on, I moved to Oxford. Here's a picture of me with my dad next to the John Radcliffe Hospital. I'd like to mention Professor Ken Murray and his wife, Lady Noreen Murray, in the top right-hand corner here. So Professor Sir Ken Murray was the supervisor for my mum's PhD. He and his wife were such an inspiration. So Sir Ken Murray had developed the first hepatitis B vaccine, and Lady Murray was a pioneer in molecular genetics technology. So they were a real inspiration because they spent their life dedicated to research, and they went to their labs every single day, well up to their 70s. So I've always had a passion for research, and I managed to find the time to do some research when a funded MD project came up through Wellcome Trust. And I had the opportunity to do my MD with Professor Nick Fisk and Professor Jenny Morgan, and here is the lab, the photo of the lab group. They were a great supervisory team, with Professor Nick Fisk having the clinical obstetric input, and the Professor Morgan having a more detailed scientific input. And of course, I had a lot of help from my research lab colleagues at Imperial College as well. So what did I do in my MD project? Well, I looked at muscular dystrophy model, and I wanted to use stem cell therapy to try and treat muscular dystrophy. It's a rare genetic condition that causes muscle weakness, and it can get worse over time. There's currently no cure, so the treatments only ameliorate symptoms. So the project was about using a mouse model, initially taking amniotic fluid from human to use the amniotic fluid to grow stem cells in the petri dishes. You spin them down in the test tubes and then grow them in the petri dishes, and then expand them into stem cell colonies. And then the idea was to transfect them with a viral vector that has the corrective gene, which would modify the stem cells, and then to transplant it back into the fetus while they were in utero. Or you could transplant them into the neonate when there were a lot of stem cell proliferation activity. So the idea was very good in theory, but as I found out, much to my surprise, perhaps I was quite naive, research is fraught with many difficulties. First of all, it was really difficult to get amniotic fluid from amniocentesis. There would be only a very tiny amount to spare. And then to try and grow them in the test tube, it was really hard to expand these stem cells because, first of all, to grow them and to expand them, and then they'd inevitably get infected and contaminated with lots of bacteria. So the experiment had to be restarted. And then when it came to transplanting the cells back into the mouse model, it was technically very challenging because I was trying to transplant these stem cells into tiny mice and doing them in utero while the mouse was still pregnant. So as you can imagine, I never had any vet training, just a mere senior house officer obstetrician, so used to very big human uteri. So it was really hard to try and conduct microsurgery. So anyway, I managed to complete the project and get an MD out of it despite all my failings, so I'm very grateful. And then next, I went back into clinical training, into maternal fetal medicine training. I wanted to subspecialize in maternal fetal medicine. So I went to the Ian Donald Centre for Fetal Medicine in Glasgow and worked under Professor Alan Cameron. Here is a picture of Ian Donald, who is the pioneer of using Doppler to do fetal pregnancy ultrasound, and here's the building named after him. During that time, I managed to do some research as well, but more clinically orientated. So I looked at, I did papers on thromboprophylaxis, papers on perinatal airway management, on babies in utero, actually, and also did a paper on pre-implantation genetic diagnosis. And it took 12 years for me to get to Kiel. So I'd like to tell you a little bit about how I got here, just in a geographic sense. So on the left-hand side is the UK. In the middle is a map of Scotland, so the top of the UK, and the bottom is England, with London blown up at bottom right-hand side. So I started number 1 in Edinburgh, and then moved down south to number 2 in Oxford, went over to the Cambridge area, did more my clinical training as a specialty trainee in obstetrics and gynecology around Cambridge, and then moved to London, number 4, to do my research at Imperial College, and then all the way back up to Scotland, in Glasgow on the other side, and finally ending up in the Midlands here at Kiel. So let's talk about Kiel. Here is a lovely image of Kiel Hall on a summer's day, which is a great contrast to what we're experiencing today. So when I got to Kiel, I wanted to continue to do basic science research. And I had great collaborators. I also worked in different disciplines as well. So initially, I continued to do stem cell research with Professor Nick Forsyth and Professor Alicia El Haj. We had a couple of PhD students, and we had a few publications on stem cells in gestational diabetes and how stem cells might work in bronchopulmonary dysplasia. I also worked with Professor Ing Yang and Professor Sean O'Brien to co-supervise PhD students who looked at the biochemical properties of fetal membranes. So these are the placental membranes from preterm birth and term birth. So I found that they had very different biomechanical properties. I also tried my hand at doing some epigenetic research as well in the labs of Professor Tony Fryer and Professor Bill Farrell, and had a couple of papers on epigenetic profiles in women with gestational diabetes and women with polycystic ovarian syndrome. But I'm very grateful to Professor Sean O'Brien, who's here in the audience, for bringing me on to the clinical research side. I'd always been quite interested in clinical research, but just didn't know how to go about it. So he was involved in this big European EU-funded multi-center study called Improve Study. And in there, we were trying to collect thousands of samples from ladies with preeclampsia, preterm birth, and small for gestational age infants. And the point of that project was to try and find a biomarker that might predict these adverse pregnancy outcomes. So it was great to learn how to do a big clinical research like this. And also, I got my first chance to do a systematic review and meta-analysis, which was on early pregnancy biomarkers in preeclampsia. And through that, I got to talk to Professor Mamas, who I'm very grateful for. He's a great mentor and taught me how to do applied health research. Having transitioned from a basic scientist to an applied health researcher himself, it was very inspiring to talk with him and learn from him. So we did a couple of papers on preeclampsia and its link to future diabetes and its link to future cardiovascular disease, but more on that later. Following these tasters in applied research, I wanted to get structured training in how to do applied research. So I applied for funding from the NIHR, the National Institute for Health and Care Research, to do a transitional fellowship. So this was a fellowship designed for basic scientists who want to learn how to do applied health research, and that was ideal for me. I had a great supervisory team, including Professor Mamas, who I already mentioned, and Professor Caroline Chu-Graham, Professor Kelvin Jordan here in the audience, Professor Umesh Kadam, and Dr. Claire Ashton. Most of them I still work with very closely today. So that has led me to my main research focus after all this training. I didn't set out to be a researcher on pregnancy complications in the first place. Like many, I began with a curiosity about how to make pregnancy safer there and then in a moment. But again and again, patients ask me, "Doctor, what will this mean for me in the future?" So their questions became my research priority, and that's why I stand here today. So we know that comorbidity in pregnancy affects pregnancy outcomes. For example, having acute kidney injury in pregnancy can increase the risk of maternal mortality by 9-fold, as well as increase the risk of heart failure and stroke by 22-fold. My clinical fellow Deepthika Jarayaman also looked at chronic kidney disease in pregnancy as well as acute kidney injury in pregnancy, and found that women with CKD, chronic kidney disease, had an increased risk of preeclampsia, preterm birth, and neonatal intensive care admission of their babies. And what about women who have survived cancer and later became pregnant or developed cancer during the pregnancy? During my research, I looked at the top 5 most prevalent cancer diagnoses, and these were skin cancer, thyroid cancer, hematological cancer such as lymphoma and leukemia, breast cancer, and cervical cancer. We found that these women face additional burdens with increased risk of preterm birth. Thankfully, there's no additional risk for stillbirth above the baseline, but in women having metastasis, these increase the risk of maternal mortality and preterm birth. So the resilience of pregnant women with past or current cancer diagnosis is very inspiring, but we must not ignore their risks in pregnancy. Modern medicine gives us new ways to conceive, but those pregnancies are not risk-free. Our studies show that women conceiving through assisted reproductive technology have higher risk of complications, including 1.3-fold increase in preterm birth and cesarean delivery, 1.6-fold increase in placental abruption, where the placenta comes away from the womb, and also 1.6-fold increase in cardiac arrhythmias, irregular heartbeat. There's also a 2.5-fold increase in acute kidney injury as well. So these are questions we must address as the number of assisted reproductive technology conceived pregnancies continue to rise. Traditionally, we treat pregnancy as a discrete episode that's just confined within the 9 months, and then it's over, you can move on. But actually, increasingly, the evidence shows it's more like a stress test, one that can reveal hidden vulnerabilities in the cardiovascular and the metabolic system. And those signals actually matter long after the baby is born. We also know that pregnancy is one of the most profound physiological stress tests that a body can undergo. The blood volume doubles, the heart works harder, and the kidneys adapt. For most women, these pregnancy physiological changes happen without any issue. But for some, especially those with underlying susceptibility, pregnancy complications can arise. And those may be the early warning signs for future disease. So moving on to preeclampsia, which is high blood pressure in pregnancy. We found striking numbers. Women with preeclampsia have 4 times the risk of heart failure, and also double the risk of coronary heart disease, stroke, death from heart attacks, and stroke later on in life. They were also twice as likely to develop diabetes in the future. So preeclampsia is not just a pregnancy problem, it has lifelong implications. For preterm birth, there's a similar story as well. It's not only the baby who faces long-term risks, the mother does too. Women who develop early faces up to 60% increased risk of coronary heart disease and stroke. There's also a doubling in risk of coronary heart disease death. Again, the pregnancy leaves echoes that reverberates throughout life. And so perhaps we can start to think about pregnancy complications as a continuum in a life course journey. Starting on the left, we have a teenage girl who might already suffer from high blood pressure, obesity, insulin resistance, or high cholesterol. That puts her at higher risk of developing pregnancy complications, such as small for gestational age babies, preeclampsia, preterm birth, gestational diabetes, and miscarriage. The mechanism is thought to be because of the placenta not working properly or the maladaptation of the heart and the good metabolic system during the pregnancy. And later on in their life, they're at higher risk of having stroke and coronary heart disease. So, why do these links exist? What are the possible drivers? We think that it might involve the heart or the lining of blood vessels. There may be the reduced blood flow in the placenta that's affecting the underlying physiology, or there may be long-term inflammatory responses. But I think it's more likely to be because of the shared risk factors between cardiovascular disease and pregnancy complications. Alternatively, there might be shared genetic susceptibility as well. But much is still unknown. We don't really know what's happening. We don't really know why this is, what the mechanism is. And for me, that's really exciting because that means there's a lot of work yet to be done. So if a pregnancy is a stress test, then the obstetric history is the results test. It should be part of every woman's cardiovascular risk assessment, really. If you have a woman who had preeclampsia at age 28, and then later on when she gets to the age of 48 and develops some sort of heart disease, she should not be told that it came out of nowhere. We can do better than this. We can use pregnancy as a screening test to work out who will need more lifestyle support for increasing their exercise and making healthy choices for their diet and weight management, and also monitor the blood pressure and cholesterol long term. In my ideal world, the adverse pregnancy outcomes would be incorporated into the atherosclerotic cardiovascular disease risk assessment. So on top of the traditional cardiovascular disease risk factors, such as high blood pressure, high cholesterol, diabetes, smoking, and physical inactivity, I'd like to see people assessing for adverse pregnancy outcomes as well, such as preeclampsia and preterm birth, and using these as additional risk enhancers in the cardiovascular disease risk score. Of course, the physical exam findings can be incorporated as well, such as waist circumference measurement and blood pressure, as well as lipid profile and HbA1c measurements. This isn't just about medicine, it's about systems as well. Obstetricians and cardiologists must talk to each other. Policymakers need to see the pregnancy history as part of a preventative medicine. And the women themselves, they deserve better. They deserve to know their pregnancy stories are not just memories, but they are potential health markers for their health in the future. So my current ongoing project involved developing integrated care pathways, raising awareness amongst clinicians, and empowering women. So we're currently doing the hidden study. My postdoc, Gauri Balandram, is leading this. She's currently interviewing about 20 patients who had hypertensive disorders of pregnancy, and also 20 healthcare professionals who look after people with hypertensive disorders of pregnancy. And through this, we can find out about the lived experiences of the woman and the perspectives of healthcare professionals looking after them. And with these findings, we want to use this knowledge in a knowledge mobilization work package. So we've developed a community of practice, which is a bunch of people who are interested in the topic of hypertensive disorders of pregnancy. So these are researchers, clinicians, charities dealing with preeclampsia. So we all get together in a room and brainstorm using the interview findings to try and co-produce a resource, like a patient resource. And this will be used to self-manage the heart health for women and to improve their knowledge about this topic. And eventually, this patient resource will be refined, and we will find strategies to try and implement these patient resource in a patient-friendly way. This month, I'm supposed to start the bundle cardio study as well. And this is a very similar study to the hidden study, except this time the output is for clinicians. So we're planning to come up with a care bundle, which is a set of guidelines for clinicians who look after women with hypertensive disorders of pregnancy. How will we come up with that care bundle? Well, in stage 1, we'll do evidence synthesis, systematic reviews of the literature, and also at the same time looking at real-world data analysis through electronic health records of primary care physicians, and just to see whether women with hypertensive disorders of pregnancy are actually getting that follow-up in their blood pressure and in their cholesterol checks after pregnancy. And of course, the findings from the hidden study will be used as well. And together with a bunch of stakeholders, we'll co-produce this care bundle. And it will be tested in either primary or secondary care. It depends on what the care bundle looks like, if it's going to be secondary care orientated or primary care orientated. And then we'll refine the care bundle after the testing phase. So my vision is simple. Every pregnancy complication should trigger a proactive follow-up. We need the research to back this up and the policy to make it happen. So I'd like to develop long-term cohorts and follow women up after pregnancy complications. I'd like to do mechanistic research as well, going back to my basic science roots, so that we can work out what the underlying mechanisms are. Prevention trials are very important as well, because that's what gives that direct patient benefit. And of course, guideline change, so that a changing practice can be implemented nationally and internationally. So, in conclusion, what happens in pregnancy rarely just stays in pregnancy. The pregnancy is not just the prologue to the baby's life, but also a chapter in the mother's lifelong health history, and as well as her future story. And prevention starts as soon as the baby is born. No research is ever done alone, and so this is my thank you slide. In addition to the people I've already mentioned, I'd like to thank my mentors, my colleagues at Keele, University Hospital of North Midlands, and National Cheng Kung University. And it's not just the people I have found the photos for, it's everyone I've worked with. So apologies if I haven't managed to fit your photo on here. I'd like to thank my postdocs, PhD and MD students, and clinical fellows. The patients as well, because without them we cannot do any clinical research. And my family for their unwavering support. So here's my husband, Nick, at the bottom hand. He's always there supporting me every day. And my baby, Magnus, who is no longer a cute baby. He's now 7. He's still cute, but he's no longer a baby. He inspires me every day, and he motivates me every day. And really, he's changed my life. For the better, I think. So I'd be delighted to take your questions, and even more delighted if you could join me at the KPA pub afterwards for a drink. Thank you very much for your attention.